All right, so this week and next week, we're going to be talking about transition cows. Dr. Mon is going to be talking next week. So I just kind of wanted to set the stage and think about what our goal is with the transition cow. So, you know, when we think about the transition period historically, it was kind of thought of as a risk period. So let's avoid any major issues in this period, try to, you know, just get them through, and then we can get them on their way and start helping them out later on. But I think we've kind of shifted our perspective here. We're starting to think of the transition period as more of an opportunity, so we can really use that time to prepare the cow to be really successful in the coming lactation. So a few things that we can think of as goals for this period are, of course, delivering a live and healthy calf and making sure she has enough high-quality colostrum for that calf. We want to enable her to increase her postpartum intake really rapidly, of course, produce a lot of milk, and then ultimately we really want to make sure that she can get cycling again and have high fertility so she can get pregnant and keep that cycle going well. And in order to meet these goals, we have some requirements. So we have to ensure that we have minimal metabolic disease occurrence, so that requires minimal loss of body condition in the early lactation period. And we have to maintain as much immune function as possible, so enabling that cow to clean and repair her uterus and prevent any other infectious disease. So when we think about those goals and those requirements to meet those goals, we know a few things that can get in our way a little bit. So the big player here is the change in demand for nutrients from late gestation, when she's just growing that fetus, to the production of colostrum and milk production. So looking at this little graph here, you see the change in demand for calcium that occurs, but I could show a very similar plot for glucose or amino acids. So the cow is dealing with this increased nutrient demand. Calcium is a particularly challenging one. So here we see that the production of colostrum requires over double that of the fetus. So that extra 10 to 15 grams of calcium that she has to supply has to come from somewhere, right? So theoretically, she would have to turn over what's in her blood 10 times to support that additional demand. But she has this sophisticated system in place, so she has to get around that in order to increase that supply within a timely manner. So this is just kind of a simplified view of those hormones and tissues that are involved in increasing supply of calcium for milk production. And I just want to illustrate that there's a lot of players involved here. So the cow can't just turn on a switch and increase the supply of calcium. So what has to happen is if the cow has that increased demand, she's going to have some degree of a drop in blood calcium. And that sends a signal and causes the secretion of this hormone called PTH, parathyroid hormone. So PTH is the pivotal one that acts on these other tissues to increase supply of calcium to the blood. So we activate vitamin D at the kidney to increase efficiency of calcium absorption in the intestine. And then on the bone side, PTH increases mobilization of that stored calcium. So the skeleton is this huge reserve of calcium that can be mobilized and support that blood calcium and milk production, but all those signals have to occur. So of course you'd expect there might be some lag here. And that's exactly what we see. So this is kind of a typical blood calcium curve for a transition cow, and you can see day relative to calving is on the x-axis. And prior to calving, blood calcium is remained fairly constant, and then on the day of calving we have this dramatic drop in blood calcium. And while all those systems are trying to work together to increase the supply of calcium to the blood, it takes several days for blood calcium to normalize. So the question is, right, does it matter for the cow that she has this lag in blood calcium? In the most extreme cases, it's very evident, right? So this kind of busy diagram here shows what happens when a cow has clinical hypocalcemia or parturient paresis. So that's the red box on the bottom there. And so these lines show associations between cows that get milk fever and other transition disorders. And it's just illustrating that everything's very interconnected and kind of confirms that those milk fever cows are our notorious cows that are probably going to be train wrecks and are more likely to have dystocia, RP, ketosis, mastitis, you name it. The question that we've been looking at in the past 5 or 10 years has been, what about those cows that experience a drop in blood calcium but not to the degree where she has milk fever. So we're talking about subclinical hypocalcemia. So this figure here shows the prevalence of hypocalcemia by lactation numbers. So from lactations 1 through 6, and you can see based on blood calcium concentration, the cows that are called milk fever or clinical hypocalcemia range from about 1% in first lactation animals to upwards of 10% in older cows. But what's really interesting here is those cows that fall in the light gray area. So they have drops in blood calcium, but not to the point where we think they're going to become clinically hypocalcemic. So that can range from 25 to 50% of animals depending on lactation group. So we have this huge population of cows that are not having normal blood calcium after calving, and the question is, are they at risk for these negative downstream effects as well? So over the past 5 or so years, studies have kind of delved into this a little bit more, and so I'll show some data from a study conducted at the University of Florida where they assessed this. And in this plot, we're looking at blood concentrations of NEFA and BHBA in the 2 weeks after calving. So these are blood markers of negative energy balance, and when they're elevated too high, it indicates an exacerbated negative energy balance in those cows. So cows with blood calcium that's considered normal in the couple days after calving are shown with open circles. And you can see that those cows have lower NEFA and BHBA for that time period compared to the hypocalcemic cows shown with the solid black circles. So what's the connection here? We're talking about a calcium disorder and a negative energy balance disorder. This is a really cool study that was done in the 80s, and I just think it helps illustrate why calcium status is so important for helping that cow get off to a good start after calving in terms of energy status. So we're looking at basically the frequency and the amplitude of rumen contractions displayed in these plots here. So the top red box shows rumen contractions of a cow with normal blood calcium. And the bottom red box is showing rumen contractions from a cow that is hypocalcemic, and you can see much less frequent rumen contractions. And then when we look at the abomasum, we see something similar. So the top is normal calcemic, really strong and very frequent contractions, and then the bottom is hypocalcemic cow abomasal contraction, so very infrequent and very erratic. So you can see if we have hypocalcemia in these cows, we have this connection with gut motility, and you can see how if gut motility would be impaired, then the cow's ability to eat a lot after calving and get a lot of nutrients from that feed is going to be impaired and could exacerbate negative energy balance. So we see a similar connection with infectious disease and immune status. So it's been illustrated that cows with subclinical reductions in blood calcium have impaired immune cell function, and that's been tied to increased risk for subclinical and clinical uterine disease as well. And this is the same study where they actually looked at those cows and when they got pregnant on the subsequent lactation. So the cows with normal blood calcium is shown in the solid black line. And you can see here we're looking at survival curve. So the proportion of cows that are not pregnant by days in milk. So it's a good thing that for the normal calcemic cows that line is dropping faster. So at any given time, there's a higher proportion of cows that aren't pregnant in the subclinically hypocalcemic group. So it's impairing their ability to get pregnant after calving as well. So a lot of work has been trying to further investigate these ties, but hopefully I've kind of laid the stage that when we think about those list of goals for the transition period, impaired calcium status is certainly something that can impede our ability to meet those goals. So a lot of my work and other people right now are focusing on ways that we can manage postpartum calcium status and alleviate some of those consequences. When I think about management of calcium status, I like to think of the overall goal here. So my thought is that we want to minimize the disturbance in blood calcium that occurs. And I don't say eliminate the drop in blood calcium, because if we think about the physiology of the cow, it's required that there's some signal to those hormones and tissues that we do need to increase supply of calcium to the blood, and that is a drop in blood calcium. So to some degree, we probably do have to have a drop in blood calcium there. So our goal is to minimize the severity and the duration of that drop in blood calcium. So I'll talk about managing calcium status in kind of a four-piece puzzle here. And I won't talk too much about management, but as you guys all know, that's huge and kind of the overlying thing here, right? Social factors, stress factors, feed management factors, they're going to affect all of these other pieces, and that effect is always there. But a lot of work has gone into nutritional prevention of hypocalcemia, and to me this is kind of the preferred approach when we're talking about these disorders, especially subclinical disorders that are really challenging to identify. If we can get ahead of the game and just minimize the prevalence overall, then we're going to be not having to worry about interfering with those cows after calving. So of course we're going to be talking about manipulating the prepartum dietary cation-anion difference, and this is something we do in the pre-fresh ration. The ultimate goal here is to alter the acid-base balance of the cow. So on paper, when we look at formulation of that diet, what we're trying to do is decrease the dietary cations, so primarily sodium and potassium, and increase the dietary anions, so chloride and sulfate. So the end goal here, when the cow consumes that diet and absorbs those different minerals, is it's going to affect her acid-base balance and cause a metabolic acidosis. And this has a couple of different effects on calcium metabolism of the cow. So I think it's easier to illustrate that if we come back to this plot of what's going on for calcium metabolism. So a couple of things happen with our DCAD diet. First, we affect how that PTH hormone interacts with these tissues. So by causing a metabolic acidosis, this response is going to be more effective, PTH acting on these tissues. So when she experiences a drop in blood calcium, she can then respond really efficiently at those target tissues. The second mechanism that's going on here is the result directly of that metabolic acidosis. When the cow is trying to compensate for that, she excretes more acid in her urine. So first of all, we measure the effects of DCAD through her urine. But second, she has this obligatory excretion of calcium with that decreased urine pH. That might sound kind of counterintuitive, but remember we're talking the prepartum diet here. So prepartum, if she's excreting more calcium in the urine, that then acts on the rest of the system to kind of increase the perceived demand for calcium. So basically what we're doing prepartum is jump-starting this system. So when that urine calcium is excreted, she's going to have to compensate for that, whether it's with increased bone mobilization or increased intestinal calcium absorption. So ultimately we jump-start this system, and at calving, when she switches onto a DCAD positive ration, she can take advantage of that heightened calcium mobilization system. So that effect from DCAD is twofold there. And we've been really looking at DCAD diets for decades, honestly, and kind of refining our approach over the years. Originally, it was a strategy for preventing clinical hypocalcemia, and it's very effective at that. And over the years, we've understood that we can have further benefits with these subclinical forms of calcium disorders. So we've kind of tried to refine our approach. And some of the more frequently asked questions in recent years about DCAD feeding are listed here, and I'll talk about a couple of these today. So we're particularly interested in investigating the relative benefit of varying DCAD levels in the diet. So there's obviously a spectrum of approaches here, and I'll kind of lay those out here. So we can think of these strategies for application of DCAD in three general camps. The first one here would be focusing just on that cation side of the equation and not supplementing any anions. So maybe you're trying to get your calculated DCAD to about positive 10 milliequivalents. So I want to emphasize that all three of these approaches could be a really effective strategy for minimizing occurrence of clinical hypocalcemia, but we were interested in whether there's really benefit to pushing our DCAD to more extremes. So the second approach here would be a low potassium ration with partial supplementation of anions, so maybe getting a neutral DCAD on paper there and a slight reduction in urine pH. And then our kind of full DCAD approach here, where we're supplementing anions to -10 to -15 milliequivalents per 100 grams of dry matter. More importantly, though, here we have a targeted urine pH. So we're trying to alter acid-base balance to the point where urine pH average was between 5.5 and 6. So the question is the additional management effort and cost of implementing a full DCAD worth it when we think we can be fairly effective with clinical hypocalcemia with a low potassium ration? So that was the objective for this study. So we used 30 multiparous cows per treatment in this experiment, and this is the experimental diet composition. And so on the top we have control, which is the low potassium diet in the last slide. Medium is the partial anion supplementation, and low is the fully supplemented DCAD. So you can see these diets are pretty typical of what we would feed here. So primarily corn silage and wheat straw in those diets. And then on the bottom, we're looking at how we increase the anion concentration of the diet. So we used animate as a source of anions. And then we balanced out the other nutrients and minerals in those diets as well. This is the analyzed diet composition. So again, control, medium, and low rations. If we zoom in here on the mineral content, you can see that our potassium is pretty constant across those three diets, and a pretty good low potassium control ration there that we were targeting. And then if we look at our primary anions here, we have sulfur and chloride that are incrementally increasing as we go from control to medium to low. Then if you look at the calculated DCAD on paper here, you'll see we weren't quite as low in all of these diets as we were originally targeting, but we really set up this experiment so we were targeting a urine pH, and I'll show you how we reached those targets in the next slide here. So a few slides are going to look kind of similar. We're going to be looking at the control diet in blue, the medium DCAD diet in orange, and the low DCAD diet in gray here. So the x-axis is day relative to calving, and here we have urine pH. So if we look at that low DCAD fed group, you can see we're pretty close to our target for that entire period, right around 6 for urine pH. What's pretty interesting is when we think about the fact that our dietary DCAD on paper was incrementally decreased, we see just a slight reduction in urine pH for the cows fed medium. So suggesting you really got to get over a threshold for DCAD on paper before we have dramatic effects on acid-base balance. So looking at our blood calcium response in this trial, what we found was no effect prepartum, but postpartum, the cows fed the lower DCAD had higher plasma calcium for the couple of weeks after calving. So this fit with our hypothesis, and it showed really that the greatest benefit was for that lowest DCAD approach. We then looked at calcium status by prevalence of hypocalcemia. So we used a cut point of 2.12 or 8.5 milligrams per deciliter, just a difference in units there. And we looked at it by sampling time point relative to calving. So each bar here represents the proportion of cows within a treatment group that was hypocalcemic at each time point. So we separated out by second lactation cows and then third lactation and greater. So for second lactation cows, we didn't see any difference in hypocalcemia prevalence, despite the fact that average blood calcium was higher overall. But when we looked at these older cows, so third lactation and greater, we see that hypocalcemia prevalence was lower for the low DCAD fed cows at a few different time points here. So this kind of fits with what we would expect in terms of older cows being more susceptible to hypocalcemia. So it showed that those older cows really responded the best to those lower DCAD diets and had a more pronounced response than the second lactation animals. Looking at a couple of productive outcomes here, we saw a similar response in postpartum dry matter intake. So the cows fed the lowest prepartum DCAD had the highest intake in the 3 weeks after calving, with the medium DCAD group being intermediate to the control and low. For milk production, again, a similar response. So the first row there shows the mean milk response. And the low DCAD fed cows had about 3 kilos per day, so about 6.5 pounds per day, higher milk production over the first 3 weeks compared to control, with the medium DCAD fed cows being intermediate. So again, this fits with the intake response that we saw and suggested that the higher the improved calcium status contributed to improved performance for those cows. When we looked through 9 weeks, we didn't see any effects, so it really suggested that these differences were manifested in that immediate postpartum period. So overall, our conclusions about relative degree of DCAD in that pre-fresh diet is that the greatest benefit was really to be had in that lowest DCAD approach, and in our situation, targeting a 5.5 to 6 urine pH, and that the blood calcium response was most pronounced in older cows. And we saw that improved intake and milk yield in that low DCAD fed group. I didn't show the data. We didn't see any differences in plasma concentrations of NEFA or VHBA, but this kind of fits with the fact that both intake and milk yield were increased. So we would suppose that intake was increased enough to support that additional milk yield. So the other question I wanted to briefly address here, because it's one that comes up quite a bit, is how does the DCAD program fit into a one-group dry cow farm? So that's kind of what your facilities require or how the management best works. Do we do a full DCAD in that program or not? So this study was published in 2013, and what they did here was looked at feeding a negative DCAD prepartum, so minus 16 milliequivalents for either 21 or 42 days prior to calving, and they compared both of those to feeding a positive DCAD, and this was a low potassium control, so positive 12 milliequivalents for the entire dry period. So you can see in these plots on the bottom, the control positive DCAD fed cows are the solid black lines, the 21-day DCAD is the dotted line, and the 42-day DCAD is the dashed line. One thing they saw was that cows fed the DCAD for the extended period appeared to have a slight rebound in urine pH as calving approached. However, when we look at the productive outcomes, so here I'm showing intake, but they also had similar responses in milk yield. Statistically, the response of the cows fed the low DCAD for 21 or 42 days was not different from one another. So both were higher than the control group, but not different from one another. So to me, this suggests that, yes, the DCAD can fit well into a one-group dry cow program. There's no additional benefit to the extended DCAD feeding, but there's no detrimental effects either. So in the end, this is going to be a positive effect for our health and production of our cows. So I wanted to touch briefly on practically, using urine pH to monitor our DCAD. And this is, nothing new here, but it's such a valuable tool that I kind of wanted to zoom in on this a little bit more. So in practice, the best way to be doing this is having weekly assessments of, 12 to 15 pre-fresh cows that are randomly selected from the pen. And ideally, these cows would have been fed the pre-fresh diet for at least a week so that we know they're having the effect of the diet. And it's important that it's a consistent time relative to feeding from week to week, just because then we control a little bit for patterns of intake throughout the day. So, of course, when we think about urine pH measurement, we're thinking, okay, the average urine pH is going to tell me what's happening with the delivered diet in terms of acid-base balance. But another really useful thing from this is looking at the variation in urine pH. So more variation would be considered not a good thing, right? Because that would tell us the cows are not getting the same experience in terms of acid-base balance manipulation. So if we have a lot of variation in that number, we can then use that to kind of troubleshoot a few different things. So feeding management or pen management, things that might contribute to how the cow is consuming that diet. So that can be really powerful in trying to get the cows all to have, sufficient acid-base alteration where we can expect a consistent response in blood calcium performance after calving. So I'll pre-apologize because I know this is a lot of numbers, but it's an interesting little case study that I wanted to try to share with you guys because I think it illustrates that point a little bit. So this data was shared with us from Dairy Health and Management Services, and what they did here was measure urine pH, like I said, weekly on a farm. This is the same farm, and it kind of tracked some changes they were making, and they looked at not only the median and average, but they also looked in the variation here. And what I hope to illustrate here is that for this farm particularly, as they decreased the DCAD and urine pH, they also cut down on the variation. And that might be part of the benefit we see to some of these more aggressive DCAD approaches is getting more consistent response in the cows. So on each of these tables, the top line is the date, so it's just about weekly here. And then we have the median and the mean. So in the first few weeks here, our median is ranging from 6.4 to 7.5, so, not really reaching those targets that we would think of. And then the bottom line here is the DCAT. So they go from just slightly negative down to -12 down here, which is kind of where we would recommend. And here we see our median coming down to about 6. So pretty close to that range that we were targeting in our study. So what I think is interesting here is if we look at the standard deviation, which is a measure of how much variability there is in that measurement. At first we have 0.6 to 0.8 urine pH unit variation, and then as our average gets down, we cut that variation in half. So again, we just start getting a more consistent response in these cows. And I think that's a pretty compelling reason to A, have this urine pH data, and B, maybe get a little bit more aggressive with prepartum DCAT. So I'll kind of jump into the next section here, and this is kind of based off the fact that we still see some hypocalcemia prevalence even if we have a good DCAT strategy in place. So as everyone I'm sure that is working with farms is well aware, there's a lot of interest in treatment strategies. So everyone has their favorite supplemental calcium approach, and we're trying to build up more of a database to understand whether these things are actually effective. So I wanted to kind of go briefly through what these things are and what we know about what they actually do for the cow. So we can provide supplemental calcium to the cow in a few different ways. Couple of the main groups here are intravenous calcium and these oral calcium boluses that are available. So I just wanted to kind of highlight the goals with these different treatment options. For intravenous calcium, we're providing a huge slug of rapidly available calcium directly into the blood of the cow. So no doubt for a clinically hypocalcemic cow, that's the way to go. We've got to get her back on her feet and eating. But I will argue that it's unnecessary to give that to a cow that's not experiencing any clinical symptoms of hypocalcemia. Oral calcium boluses, on the other hand, won't provide calcium quickly enough for that cow that's recumbent or has really weak muscles and is about to go down. But it does provide a slow release of calcium salts that might be more appropriate for cows that we think might be subclinically hypocalcemic. And that's illustrated really nicely in this study that was published a couple of years ago. In this study, they had 33 Holstein Jersey cross cows, and at calving, they were all subclinically hypocalcemic with blood calcium less than 8. So they randomized them to 3 supplemental calcium approaches. The solid black line is control, so they didn't receive any supplemental calcium. The dotted line is cows that were given intravenous calcium, and then the dashed line is cows that received an oral calcium bolus regimen. So in this study, they used Bovacalc, and they received one at calving and one again 12 hours later. So what's really interesting here is looking at that intravenous calcium curve. So we see that huge spike. They go up to a really high blood calcium level. And then we see later on, after they've cleared that calcium from their bloodstream, they actually rebound below where the control cows were. So this raises the question of whether we're actually doing that subclinical cow more harm than good by giving her that intravenous calcium dose. And it kind of makes sense if you think about the physiology here. We might actually be impairing those natural signals that are telling her body to increase supply of calcium to the blood. The oral calcium bolus here, on the other hand, has kind of a sustained increase in blood calcium. So it's nothing dramatic, but it seems to remain above those control cows for about a day after calving. So that seems to be a positive thing in terms of short-term blood calcium status. But the question then becomes, do we recover any of these consequences we associate with drops in blood calcium? So a couple of big field trials have tried to assess just that, and more data is coming out all the time as people try to better understand these supplemental calcium approaches. So I'll just share a few findings from those studies. As kind of a overarching theme here, what these studies find is that there really doesn't appear to be an overall benefit to giving blanket treatment to a group of cows. So if a lot of farms do something like everyone entering their second lactation or greater, there's no overall response to additional calcium like that, like there would be in a preventative approach. But what they did identify is these subgroups of cows that respond positively. So in one study, lame cows who got a bolus treatment responded with fewer health events than lame cows who did not get a bolus treatment. In two studies now, we've seen that multiparous cows that had high previous lactation milk yield responded to a bolus treatment with increased milk production. And in another study, multiparous cows responded with reduced services per conception. So those seem to be positive responses in these subsets of cows. On the other hand, one study identified a couple of detrimental effects of bolus treatment. So multiparous cows with lower previous lactation milk yield responded to a bolus with reduced milk yield, and primiparous cows responded with increased services per conception. So that would identify that, again, with these blanket treatment approaches, there might be actually a population of cows that are not doing so well when we give them those boluses. So I just wanted to briefly touch on that because, again, there's a lot of people out there that are implementing these things, and as we get more information, it's really valuable to bring these out there and better identify how to use those resources. So just briefly, I wanted to touch on monitoring because that's another thing that's becoming more and more common out there is collecting blood samples after calving and measuring blood calcium status. So I just wanted to briefly talk about some cautions with that and some ways we might be able to use that data. Some of the challenges here is that we don't have any inexpensive, reliable cow-side tools yet. I know that some people here at Cornell are working on those types of things, but they're not quite field ready at the moment. So we have to use outside resources, send samples off to labs or vet groups to measure these things. So another challenge here is that blood calcium concentration is changing so rapidly in the few days after calving. So we can't necessarily say, let's go out and sample everyone who's 3 to 14 days in milk like we do for the HbA because the expected blood calcium is so different in that range. And then, of course, we have differences in blood calcium thresholds. So like I said, for treatments, we can't really make our decision based on blood calcium measurement. And so individual cow measurement is kind of a little bit of a reach yet still, but I do think there's opportunity for herd level monitoring. So just to quickly illustrate how that blood calcium change over the few days after calving could affect your results. This is the data from the trial that I presented earlier, and we're just looking at all cows here over those 5 days after calving. So if we were to sample cows on average about 18 hours after calving, which is that second set of bars there, the prevalence in this study was 76 to 90% of these multiparous cows. But cows that were, once they were 2 days in milk, that prevalence went down to 34 to 53%. So if we're sampling cows from calving to 2 days in milk, the expected prevalence is going to be really different in that range. So this is something you should take into account when you're making these measurements. So just a few pointers here. If you're going to be implementing this, make sure you have a tight window of timing after calving to make sure you have comparable data. Take parity into account. I didn't talk about heifers too much, but we know they're a different beast when it comes to hypocalcemia. If any prophylactic calcium is used, that's going to affect your results, so take that into account. And ideally be sampling before prophylactic calcium. And finally, we don't really have herd level alarm rates for hypocalcemia prevalence. So we can't necessarily say your target should be less than X% of cows that should be hypocalcemic. But if we establish this as a regular monitoring tool, changes in prevalence over time can tell us something about how management and other factors on the farm are playing into how we're doing in terms of calcium status. So just a few take-home messages here. I think we're learning that these more aggressive BCAD approaches are really beneficial in terms of calcium status and productive outcomes. I didn't talk too much about other minerals and how they play into it, but we know that those are important for the success of those diets as well. Oral calcium bolus supplementation, I think, has a role in managing calcium status, but we really should think about targeting those treatment strategies to subpopulations within the herd. And then if we start this herd monitoring, we might be able to better understand the role that our management and nutrition play into hypocalcemia within individual farms. So with that, I'd happily take any questions. And like I said, please feel free to email me so that we can talk more about it.